Okay. So I was asked to talk about when and how to use liquid biopsies in early stage as well as metastatic colorectal cancer. And as you know, this is quite an evolving modality that's being used right now, mainly in the metastatic and heading towards the early stage colorectal cancers. And I'm going to give you some of my thoughts as to where I think the future is headed for liquid biopsies in this realm. Now, why do we profile tumors? We profile tumors because we want to find targets, because as you can see on the slide over here, in patients with non-small cell, pancreatic, breast cancer, as well as colorectal, when you match appropriate targets to appropriate therapy, you're in fact improving prognostic outcomes. And you can see patients with highly actionable alterations who received a molecularly matched therapy lived longer than patients who did not receive a molecularly matched therapy. Now, this was a very interesting paper that came out from a Memorial Sloan Kettering colleagues in which they profiled over 10,000 patients in a prospective fashion who had metastatic cancer. And you can see a large proportion of those patients, in fact, had some form of a GI tumor, either colorectal, pancreas, biliary, GE junctions, or hepatocellular carcinomas. And a large proportion of these patients, in fact, had druggable mutations, making it important for us to be able to determine these mutations so that we can appropriately target them. Now, in patients with colorectal cancer specifically, because that is the theme of our topic today, you can see that a good proportion of these patients actually have hypermutated tumors, making them eligible for immunotherapy. And the non-hypermutated tumors also have various mutations that can also make them eligible for a plethora of different therapeutic agents, which we will talk about later on. Now, coming to the concept of liquid biopsy, because most of what I've shown you so far has really depended on the mechanism of biopsying a tumor and sending that tissue specimen for profiling. But how can we make it easier for the patient and make it easier for ourselves? And that comes from the use of liquid biopsies. So what are liquid biopsies? Basically, you take a sample of a patient's serum, and these tumor cells are released as small fragments of cell-free DNA into the circulation, and these are actually captured. And these are cancer-associated genetic alterations such as point mutations, copy number variations, chromosomal rearrangements, and methylation patterns that can be detected from these circulating cell-free DNAs that we essentially call as liquid biopsies. And you can see over time, the number of PubMed citations for these different publications pertaining to circulating free DNA has increased substantially. And when I looked it up last night, it has multiplied by almost a factor of 4 in 2021. Now, when you're looking specifically at colorectal cancers, is there a good correlation between tissue profiling and liquid biopsies in terms of detecting those mutation frequencies? And you can see this from an amazing paper that was published in Cancer Discovery by Stickler and colleagues. You can see that there is a good correlation between those comparisons of mutation frequencies, especially the frequencies of mutations that we tend to focus on in patients with metastatic colorectal cancers. And so when you're thinking about liquid biopsies, there's increasing evidence to suggest that circulating tumor DNA may exhibit a complementary role to the existing modalities that we already have, such as tissue profiling, to determine treatment targets, to monitor patients, to try and identify mechanisms of resistance as well as response to therapies, to be able to identify those rare genetic alterations, and of course, detect minimal residual disease. Now, the way I've put it is I think liquid biopsies in clinical practice has 3 main applications. The first is in metastatic disease, where we look at profiling the tumor, looking at that treatment response, resistant mechanisms, and of course, heterogeneity assessment. So let's go through that very quickly. In terms of access to tumor, we know that when we're trying to attain tissue material, we often have the problem of getting insufficient material as well as insufficient access to that tissue in terms of maybe an inaccessible site for biopsy. And this frequently happens in the clinic. And then, of course, you've got cost, risk, and time. We know that it is costly to get those biopsies done, especially liver and lung biopsies. You can see the financial costs on the screen there. And of course, any intervention does carry a risk of complications associated with it. And in a Medicare analysis, 19% complication rate was associated for intrathoracic biopsies that we may be trying to chase. And again, something that we could avoid with a liquid biopsy. What about speed of results? This was a very nice study that came from our Japanese colleagues. It was a large genomic screening program that took place in Japan. You had the GI screen, which looked at tissue profiling, and the Godzilla study, which looked at liquid biopsy profiling. And you can see in terms of turnaround time, using circulating tumor DNA significantly reduces the turnaround time versus tissue testing. You can see a median of almost 21 days with tissue versus 8 days with plasma. And even the quantity not sufficient problem is significantly reduced from 10.6% to 0.1%. When you're looking at those actionable alterations, very similar between tissue and plasma, but interestingly enough, a higher proportion of patients who had circulating tumor DNA actually had enrollment in clinical trials. And when you're looking at that progression-free survival based on those matching of targets, there didn't seem to be a difference between tissue as well as liquid biopsy. Now, what about rapid dynamics? What do we actually mean by that? Well, when we look at ctDNA falls in a patient who is being treated with therapy, it may actually help you plan therapy. And we know that the half-life of ctDNA in the circulation is measured in minutes to hours. So it can actually give you real-time evaluation of how your patient is doing. And I think it's specifically useful in those patients who've got stage 4 de novo disease, supposed disease that is located only in the liver, where you're trying to reach that NEDE state. And you're trying to determine when to actually incorporate surgery in these patients, and even trying to avoid toxicities in these patients where you know that the treatment may not be working. What about determination of biomarkers? Well, in terms of determination of biomarkers, we know that in colorectal malignancies, and I mentioned this right at the very beginning, there are so many different biomarkers, and this is a very simplistic algorithm that I've put together that are important for patients with that stage 4 CRC tumors. We need to determine the RAS status, the BRAF status, HER2, MSI, as well as those TRK fusions, which we know are important, especially acquired over time. And I'll show you some data for that. Now let's look specifically at HER2, which is becoming a very important target for our patients, because there's a lot of evolving information looking at anti-HER2 therapy for these patients. We know about 5% of these patients with RAS wild-type disease actually have amplification. We've had data looking at trastuzumab lapatinib, pertuzumab TDM1, trastuzumab and pertuzumab, as well as trastuzumab deruxtecan, that have all shown responses in these patients who are refractory to standard of care therapy being anywhere between 30 to 50%. Now, can liquid biopsies help us determine these HER2 status? The simple answer is yes. This was a very interesting poster that was presented at ASCO this year that looked at the correlation between HER2 amplification in tissue as well as liquid biopsies, about 353 patients from a retrospective multicenter global study. And what the authors concluded was HER2 amplification could be reliably identified using both tissue as well as blood-based assays. But what for me was more interesting was that there were some patients that you would miss with tissue and that you would miss with liquid biopsy in terms of trying to determine that HER2 amplification. So making me think that perhaps we need to be doing both when one is negative versus the other. Now, this comes from the Heracles A study, which looked at using pertuzumab and trastuzumab in those HER2 amplified patients. And here, just as a snapshot view, looking at tissue versus plasma-based HER2 amplification detection. And you can see when you are trying to determine HER2 amplification using cell-free DNA, you have a 97.9% sensitivity in terms of detecting HER2 amplification. population. And this can be used to select patients who can in fact benefit from the combo therapy, where we know we have a very high response rate in these patients, nearing almost 53%. Now, MSI has become the cornerstone of testing in patients with colorectal cancers, because we know that patients who are MSI high disease, the first-line therapy in these patients is the use of pembrolizumab. We know that from the Keynote trial, and you can see from the previous trials that the use of pembrolizumab in these tumors is actually MMR. MSI is actually an agnostic marker, but specifically in patients with CRC tumors, first-line therapy is actually, in patients with MSI high disease, is actually better than using standard of care chemotherapy. Now, can we actually test for this in a patient where we only want to do a liquid biopsy? And this was an interesting phase 2 trial that actually looked at the correlation of ctDNA as well as tissue in terms of determining MSI high disease. There were 16 patients with ctDNA who had gastric cancer, who had MSI high disease, and there was almost 100% concordance with tissue-based MSI testing. So again, an alternative to actually testing for that MSI status in your patients who've got metastatic disease. Now, I think one of the biggest areas of using liquid biopsies in metastatic CRC patients is actually assessment of resistance. Now, why is this important? Well, it's also not important only for colorectal cancer patients, but we're tending to do that for patients across solid tumors, because we know that as we're treating more and more patients with targeted agents, more and more patients are developing acquired mechanisms of resistance, and they are targeted therapeutic options for those patients. We know in patients who have RAS, BRAF wild-type disease can eventually acquire a RAS mutation. Similarly, in breast cancer patients, lung cancer patients, and other patients with solid tumors, you have those acquired mechanisms of resistance where there are targeted agents. Now, coming back to that algorithm that I put together right at the very beginning, looking at patients with metastatic colorectal cancers, where you have this plethora of different targets, such as RAS, BRAF, HER2, MSI, and TRK, we know that patients with RAS wild-type disease, when you give them anti-EGFR, they tend to do very well. There's a response rate of about 40%, but these patients eventually develop a resistance to anti-EGFR, and they progress on panitumumab or cetuximab. So the question then comes up, could you potentially re-challenge these patients later on? Can ctDNA help us identify cohorts of patients we can re-challenge with an anti-EGFR? Because we do know that these patients have multiple mechanisms that can help cause resistance to panitumumab as well as cetuximab in those initially RAS wild-type patients. And what's more important is we know that these resistant clones are transient, and they regress after actually removing anti-EGFR therapeutic agents. So potentially telling us that we could potentially re-challenge these patients. Now, there was a very interesting phase 2 trial that was actually presented at ASCO this year. I thought it was really interesting. It was the Kronos trial, in which they took patients who were initially RAS and BRAF wild type, treated them with an anti-EGFR regimen plus chemotherapy. These patients then had to progress. And when they progressed, they had to have a period of time where they didn't have an anti-EGFR agent, allowing those resistant clones to come down in their levels. And then they had a liquid biopsy trying to determine who had a mutation versus not. Interestingly enough, you can see that 25% of patients had developed a RAS mutation, of which 6% actually had a G12C RAS mutation, making it interesting because we know that there are targeted agents towards this. But more interesting than that, you can see about 2% of patients actually develop a BRAF mutation, where we know that there are, again, targeted therapeutic agents for these patients. Now, looking at those patients who did not develop a RAS mutation, these patients were treated with single agent panitumumab, and you can see a response rate of almost 30% and a control of disease rate of almost 63%, suggesting that if you pick and choose your patients, you can re-challenge these patients with an anti-EGFR agent. Now, what about patients with HER2 amplification? We know that these patients, if they have a RAS mutation, giving them anti-HER2 agent will not work in these patients. You need them to be both HER2 amplified as well as RAS wild type. And so this is the TRIUMPH study, which I thought was very interesting, which took patients who had been treated with standard of care chemotherapeutic agents that were refractory to these agents, including anti-EGFR, but they had HER2 amplification, and they were treated with pertuzumab as well as trastuzumab. And they underwent both liquid biopsies as well as tissue biopsies to be profiled. And you can see from those ctDNA mutations that some of these patients had acquired a HER2 mutation, KRAS mutation, as well as BRAF and TP53 mutations. Now, when you treated these patients with pertuzumab as well as trastuzumab, if they were quadruple wild type, and remember that quadruple wild type intended for these patients to be RAS, BRAF, PIK3CA, as well as HER2 mutation wild type, these patients had HER2 amplification, they did much, much better than if you had any one of these mutations, really suggesting that liquid biopsies can actually help you identify patients most likely to benefit from anti-HER2 therapy, such as dual blockade, pertuzumab, as well as trastuzumab, and can be used to monitor response and detect actionable resistant biomarkers. Now, these resistant mechanisms can also help you treat your patients who have acquired these resistant mechanisms. And I thought it was very interesting from that Japanese study, from the GI screen Godzilla study that I talked about earlier on. When you looked at these patients who had sequential ctDNA, you can see about 27% of these patients develop RAS mutations as well as fusions such as FGR1, as well as RET fusions, but they're very, very small percentages. And so the question then comes, these resistant mechanisms of acquiring these fusions, which occur in about 1.1% of these patients who have initially RAS wild type disease, they could potentially be candidates for targets such as targets against RET, targets against NTRK, as well as ROS1 and FGFR. And so these are very interesting questions to ask in the future. And I think acquired mutations are just as important as those resistant mutations that prevent you from using specific therapeutic agents. So is the algorithm that simple? It is not. You can see it's very complicated because the algorithm gets more and more complicated with time as you have more and more resistant mutations that arise. So in my mind, when you're looking at the tumor dynamics of patients receiving biomarker selected targeted therapies, you need to look at it logically. You need to look, when you're treating your patients with anti-EGFR, you need to understand that there will be growth of resistant clones, and you may then give a holiday from that targeted therapy and then follow it by reintroduction. You could change treatment therapy based on emergent biomarkers, or you could potentially introduce agents that are active against those downstream targets, like I mentioned earlier on. So finally, what about evaluation of heterogeneity? We know that heterogeneity is something that can cause a problem, especially when you're trying to do biopsy of tissues. One part may have a different molecular profile versus another part, and this is more visible in patients with GE junction tumors more than CRC tumors, and you can see that from a study that actually looked at the distribution of gene amplifications in primary and metastatic lesions in GE cancers. And you can see that if you did only a single lesion biopsy, you could miss up to 1/3 of amplifications that you would want to know in terms of HER2 amplification, in terms of treating these patients. And not only that, you can see over time, HER2 amplifications can be either persistent or lost. So again, you need to be able to track these patients over time. Now, what about in that cohort of patients where you've actually treated them in the early stage setting, and you want to be able to detect early recurrence and perhaps escalate or de-escalate adjuvant therapy? So really the whole concept of minimal residual disease has come from the detection of ctDNA to be able to determine both prognostically whether a patient is going to do well as to try and predict if patients need additional chemotherapy. And you can see here from this slide, in terms of tumor burden, once a patient actually has had surgery, you can have either the ctDNA becoming undetectable, or there is still ctDNA present where these patients can actually do worse. And so the definition of minimal residual disease is actually defined as detection of ctDNA with no other clinical evidence of disease recurrence in patients who have completed all potentially curative therapies. Now, there's been a number of studies to see whether prognostically this makes a difference. And this was one of the first studies that I thought was very interesting, presented by Reinhardt and colleagues and published in JAMA Oncology in 2019, in which they took patients with stage 1 to 3 colorectal cancers who had undergone surgery, who had had their ctDNA measured 30 days post-surgery. And you can see those patients who had ctDNA negative versus positive. The positive patients were 7 times likely to relapse. Once you detected the ctDNA post-adjuvant therapy, these patients were 17 times more likely to relapse. And of course, if you detected a ctDNA while you were doing surveillance for your patient, that means at different time points, they were 43 times more likely to relapse. Now, when you look specifically at those patients with stage 2 and 3 disease, when you substratify them, it makes you wonder, those patients with stage 3 disease who are ctDNA negative tend to do very good. And do these patients actually require adjuvant chemotherapy is the question we ask. And stage 2 patients who are ctDNA positive and they do very badly, do these patients also require adjuvant chemotherapy? A question that we tend to ask ourselves multiple times, especially in stage 2 patients, where we have these clinical risk factors that we try to determine who needs chemotherapy versus not, including determining the MSI status, as well as other risk factors. And you can see that even in those patients that we think have clinically high risk, you can see if they have ctDNA that's positive post-op, they will do badly. And those patients with clinical low risk, if they are ctDNA positive, again, they will do badly, suggesting that these clinical risk factors are not enough. Now, the problem with the previous papers that I've shown you is that those ctDNAs to determine MRD assays actually requires tumor sequencing to identify tumor-derived mutations to facilitate ctDNA detection, requiring tumor and blood. Now, if you wanted to be a lot simpler, so you didn't want to do 2, this was a very important study that looked at a Guardant assay, that looked at the evaluation of plasma-only ctDNA assays, integrating both genomic as well as epigenomic cancer signatures to enable tumor-informed MRD detection. And you can see if you used a simple assay like this, you can see again, if you're ctDNA positive post-op, again, you do very badly. And the sensitivity of this assay was 55.6% with a specificity of 100%. And again, this assay incorporates both genomic as well as epigenomic markers that in fact gives you the highest sensitivity as well as specificity. So these findings could support the potential clinical utility of plasma-only ctDNA for MRD detection. But remember, this MRD detection and the time to actual clinical recurrence that's detected by a CT scan or a PET CT scan, there's a lead time bias of about 8.1 months. Now, if we treat these patients earlier, is it going to make a difference? Now, the other area that I think is interesting in that early stage setting is rectal cancers, because we know that treating patients with rectal cancer neoadjuvantly has a whole plethora of different questions, something that I'm not going to go through. But as we know, there's been questions about whether giving neoadjuvant therapy is enough. Do these patients actually need surgery? Do these patients, can they have only chemoradiation therapy upfront versus no neoadjuvant chemotherapy, and all sorts of other plethora of questions. Now, I thought this was a very interesting poster that was presented at ASCO this year that looked at that question of doing ctDNA in those patients with early stage rectal cancers prior to neoadjuvant therapy. And interestingly enough, they found that patients who had positive ctDNA plus a positive CRM actually did much worse than those patients who had negative ctDNA and negative CRM. So the National Task Force for ctDNA in colorectal cancers have actually posed some very interesting questions that I think in the future we will need to answer for rectal cancers, and that is defining the role of cell-free DNA in determining prognosis of these patients, changes in ctDNA as markers of the degree of response in order to tailor the intensity of neoadjuvant therapy, and can some of these patients perhaps not not need surgery, a question that we ask after neoadjuvant therapy in the rectal cancer realm. So as you can see, patients with ctDNA minimal residual disease, there may be opportunities for escalation of standard therapies, and those that are ctDNA negative, there may be opportunities for de-escalation of standard treatments, but there's a whole plethora of questions that are still important that we ask before we implement it into standard clinical practice. But I just want to show you that the NCCN guidelines, the consensus opinion is that the evidence of predictive value in terms of the potential benefit of chemotherapy is still lacking. We know it is prognostic, but we don't know if it's predictive, and we don't know how to appropriately treat these patients. So I still think we have a long way to go before we implement it into clinical practice. So finally, what about screening? I think screening is also going to be a huge avenue to explore in terms of using liquid biopsies, and we know that the LUNAR-2 test that comes from our Garden colleagues has been actually looked at in terms of looking at somatic mutations that may help you determine if patients have colorectal cancer or not. And this was a very interesting study that took patients who were detected by colonoscopies and then determined to have stage 1 to 3 disease and had ctDNA at the same time. And you can see that using the LUNAR-2 test was associated with a 94% specificity and sensitivity was maintained at stage 1, 2, as well as stage 3 patients. And it didn't matter if patients had right-sided or left-sided tumors. So multimodal ctDNA assessment has a high sensitivity for CRC detection with a high specificity. And I'm more excited about this realm. So in my final slide, these are my thoughts as to where I tend to use liquid biopsies in patients with CRCs. So I think it's very important to understand that there's a quick turnaround time to determine biomarkers of importance. And I tend to do this a lot when I know that that tissue biopsy is going to take a long time. It allows us, and this I use it frequently, to determine resistant biomarkers post anti-EGFR therapy. And I think we have enough data for these two areas in terms of mCRC patients. Can we use it to monitor disease response for early therapeutic management? I do think that there is a role, especially in those patients with limited liver disease, where we're trying to reach an NED state, and monitor patients who are at high risk of relapse. Again, I think it's those same cohort of patients that we can perhaps in the clinic do it now, where we have patients with limited liver metastases. We give them chemo, we resect everything. We know that they're at very high risk of relapse. And I think at least now in terms of adoption, this would be the area. And also to determine MRD to de-escalate or escalate therapy. I don't think we're there yet in terms of predicting who should or should not get chemotherapy, but I do think that in the clinic, as physicians, as medical oncologists, you may want to think about it in your patients with stage 2 disease, where you don't know what to do with these patients. And there's always that conversation, should you be giving chemotherapy to these patients or not? So I think at least if you wanted to adopt it, this would be the area to adopt it right now. And perhaps also in those rectal cancer patients who are refusing to undergo surgery and where you want to intensify their neoadjuvant therapy, I think this would also be an area to explore actively in the clinic. So thank you very much.
Thank you, Dr. Shaheenah. It was a wonderful presentation, exactly what I wanted. I have a couple of questions and we have time, Ravindra, right? Okay. Right. Before the next session, we have time, Ravindra, right?
Yeah.
Okay. So the first question, and this comes up quite frequently, is let's say patient has underwent a colon surgery 3-4 years ago and now presents with lung-only mets, and the biopsy is not possible. In your clinical practice, do you use liquid biopsy to confirm a diagnosis?
That's a very interesting question. I don't use it to confirm a diagnosis, but if I'm unable to biopsy these patients, I will do ctDNA just to, if I'm, so I take the case to the MDT. If the MDT, everyone says, look, this is recurrence of your colorectal cancer patient, we will treat it as colorectal cancer, but I'll do a ctDNA just to look at those biomarkers. So that for me is important, but am I going to confirm a diagnosis with ctDNA? Absolutely not for the time being.
Okay, because recently we had a case who presented just 3 years after a colon surgery, and the tissue diagnosis was a problem, and it turned out to be a lung cancer, carcinomatosis, and it was not a colorectal cancer. So tissue diagnosis was an important concern there. So as I understand, current liquid biopsy tests do not allow us to confirm a diagnosis. Is that correct?
It doesn't allow us to confirm a diagnosis in a colorectal cancer patient. I have to admit, in patients with lung cancer, that is a different ball game altogether. And I have had actually one patient. She was an 80-year-old lady who came to me. Actually, her son we could biopsy it. Her son just absolutely refused to do a biopsy because she was 80. And we did do ctDNA at that point, and she had a clear EGFR mutation because she was a non-smoker. You know, she fit all the criteria. At that point, if you have your MDT's consensus that you can actually treat, and I know there are ongoing trials right now specific for lung cancer that are looking into this possibility where you don't need tissue to actually diagnose, I would do it at that point. But for CRC, I don't think you can make that diagnosis with a ctDNA.
I agree. There's another question there. Let's say patient has underwent a surgery in adjuvant therapy. Many a times we see CA going up slightly.
Yes.
Your scans are negative and your colonoscopies are negative. Would you at this point try and do a ctDNA?
So you're talking about when you are following your patient up longitudinally over time? No, I would not do a ctDNA. And the reason why I wouldn't do a ctDNA in these patients, because I finished treatment, and even if the ctDNA is positive, we have no data to support that early treatment of these recurrent patients is going to improve prognostic outcome. And that's why I think we need to wait for that data of those interventional studies before we rapidly adopt it over time. It just causes a lot of anxiety and nothing else.
I agree. And the last question is that let's say your patient is on anti-EGFR. When you test for mechanisms of resistance, how often do you check? So do you always do a baseline ctDNA workup when you put a patient on EGFR, anti-EGFR?
So baseline, if I have a tissue profile done already, I won't do a baseline ctDNA because cost is there, because it does cost a lot to do both. If I can do both without a cost implication, I do both of them. I would treat with the anti-EGFR, and then when they progress, I don't do a ctDNA at that time point. I change my therapy. I wait for the patient to progress again. And then if I want to re-challenge, at that point, I'll do a ctDNA to make sure that that patient is RAS wild type before I re-challenge, because re-challenging in a patient that is RAS mutant is not going to work. Plus, I think it's very interesting from the Kronos trial and some of the other studies that shows that you can acquire other types of mutations that can help you actually target. And I think that's what's really important. So I would do it, but there has to be a gap between your first and your second.
I agree. So you need to let the washout, you need to wash out. So
Exactly.
coming back to the Kronos trial, they had 4 alterations: KRAS, NRAS, BRAF, and EGFR ectodomain.
Yeah.
Despite all of them being negative, still almost 30% outright progressed.
Yes.
What do you think was the mechanism there? That means we still don't know enough about anti-EGFR, right?
Absolutely, absolutely. I think that we need to probably be targeting some of the downstream signaling pathways. I think panitumumab and cetuximab, I think we've reached the height of it for the time being. And I know that there are other drugs that are coming up that are trying to attempt to do that. But as of now, in the clinic, this is what we have. And I don't think we can do anything else apart from enrolling these patients on clinical trials.
Great. There's one question from a surgeon that after rectal cancer treatment, neoadjuvant treatment, and a consolidation treatment, patient has a complete clinical response. Would you use ctDNA to say, I'm going to do wait and watch versus, I'm going to operate?
So I have these conversations all the time with my patients. As of now, my recommendation outside a clinical trial is that they should have surgery. If they're on a clinical trial, that's different. But outside of clinical trial, they should have surgery. Now, you do have patients that absolutely categorically refuse to have surgery. Those are the patients I tell them, okay, let's do a ctDNA. If it's positive, I really suggest that you have your surgery done. And if it's negative, then perhaps we can monitor you. So I think that there is a role for it. And I think in clinical practice, no matter what the NCCN guidelines tell us, we need to incorporate it because you do have patients that will not follow the guidelines. So I think that there is a role for it, but in a specific group of patients, with the caveat that they understand it's not standard of care.
Great. So that's all. I think so we answered all questions. Thank you, Dr. Shaheenah. It was a
Thank you,
wonderful
Pradeep.
presentation.
Thank you.
So much.